Hello, good day, Mrs. Mary Grace Odulia O. Amok, RN. My name is Joshua Go from Bachelor of Science in Nursing Level 3. I am here going to demonstrate the neurologic assessment. What is this? It is the initial neurological assessment, which is a comprehensive examination covering such as the several critical areas of your assessment, including the level of the consciousness of the patient, orientations like speech, expression or facial symmetry, motor and sensory function, and reflex activity. Also, it is the assessment of the cranial nerve function, cerebellar function, and reflex activity are covered in the comprehensive neurological function assessment. And then we have to use also in this procedure, we have the Glasgow-Coma scale or the GCS in short. And then also it is a valuable tool for recording the consciousness of the state of the patient of a person is based on the 3 patient responses like the eye opening, motor responses, and verbal response. The total score will range from 3 if the patient is coma, maybe. And then we have 15 for full consciousness of the patient and alert and oriented. And then if 7, maybe the patient is lower, usually indicates a coma. And then what is the purposes of this procedure? Purposes of this procedure are to assess the nervous system of the function of the patient. And then also we have to determine the highest level of functional ability of your patient. And then also to detect the neurological patients like injury of the patients, monitors progression, and to determine the type of the care we need to provide, and to monitor the patient's response to the interventions, and also to identify teaching needs to evaluate patient outcomes also. And for materials and equipment, make sure that everything is ready. Now, you have neurological observation record, which I'm holding right now, my pen, and a pen light, of course. Then also you need a thermometer for this one, and then a sterile cotton applicator or a cotton balls, your cotton whisk, snail lens chart, which are in the board of the patient, and then you have need a test tubes, a safety pins, and lastly a reflex hammer. And then as a nurse, we are following the basic guidelines of the nursing process. We have the assessment, planning, implementation, evaluation, and then document. Now, for the procedure proper, we have to assess first for our assessment. We're going to check for any medical condition of your patient if you're working, for example, in the ICU, and then may affect the accuracy of your assessment if the patient is coma. And then we have to check for the vital signs, specialist, the current progressive if the patient is having head injury or injury to the brain, and brain system may take the vital signs which is make him or her unstable. And then also we have to which could reduce to neurologic response is best we have to conduct a neuro assessment for this one at the time when the vital signs are relatively stable. And then we have to assess that our environment is conducive for the conduct of the procedure. And for our planning, we're going to gather our equipment to help save time, effort, and energy. And then for the implementation or the procedure proper, this is how it is done. Implementation or procedure proper. Explain first the procedure to the patient. If unresponsive the patient, wash your hands and provide privacy. So for assessing first the Glasgow-Coma scale, if the patient is, number 1 is for the eye opening. For the eye opening, make sure that the patient is, if it is spontaneous, you give a score of 4. Observe the patient's eyes. A patient that has eyes that are open, spontaneously receives a score of 4. And for the voice, supply vocal stimulus by asking the patient loudly and clearly to open their eyes. If there no response by opening their eyes, they receive a 3. Or they have response. And for the elicit pain, response by pushing down behind the ear, anterior to the mastoid process. You can also push down on the patient's fingernail bed. If the patient then opens their eyes, they receive the score of 2. And then if there's not response to pain, the patient will receive 1. And for the verbal response, for verbal response, if the patient is oriented, whether the patient is oriented to the time and place, patient response will receive the score of 5. Ask the patient question which know the answer to, such as what day today is, and do you know where you are at that moment. If confused, you give 4 if the patient appears slightly confused and are disoriented for the conversation they receive. If inappropriate speech, if the patient has a random or muddled speech without exchanging of information during During the conversation, they receive a 3. If the patient is incomprehensive, if the patient is making sounds but is unable to formulate words, they receive a score of 2. If none at all, a patient that is unable to produce sounds receives a 1. Thus, these do not refer to aphasia due to any cause such as airway obstruction or laryngeal injury. To check for the motor. For motor, if the patient obeys command, a patient who responds to you and does what you ask receives a 6. In the order to assess this, shake the person's hand upon arrival or ask them, I can hold your wrist to take your pulse. Localize the pain. Elicit a pain response through a techniques previously mentioned. If the patient pulls away from the stimulus, they receive a 4. If abdominal flexion or decorticate, the patient explicit a pain response through techniques previously mentioned. If the patient's arms move toward their chest, their fingers and wrists flex on their chest, and they point their toes, they are said to have decorticate. Pursuing to receive a 3. This posture indicates of head injury and a patient may present in this position prior to any patient stimuli. And then for abdominal extension or the decerebrate, explicit pain response through techniques previously mentioned. If the patient's arms and legs extend, the wrists rotate away from their body and they point their toes, then they are said to have the decerebrate. Posturing and receive a 2. This posture is also indicative of a head injury and patient may represent this position prior to any painful stimuli. If no response at all, the patient receives 1 and the patient does not have a motor response receives a 1. So add all the numbers from each section by eye opening, best verbal, best motor response, and document in the total section of the record. A score of 3 is the lowest and 15 are the highest. A score of 7 or less indicates coma and GCS 8 9 severe brain injury dysfunction. If 8 or 9 or 12, moderate brain injury dysfunction. And then if 13, minor brain injury dysfunction. This alert are awake enough to answer question, assess level of orientation to person like place and time, ask what is your name, where are you right now, what is here today, who is the person in the room. The pupils and eye movement, ask the patient to open their eyes. If doesn't respond, lift his upper eyelids, inspect each pupil's size and shape, and compare for quality of note if the pupils are positioned in that or deviate from the midline. Test direct light response, hold each eyelid open in turn, keeping the other eye covered. Swing a pen light from the patient's ear toward the midline of the face. Shine the light directly into the eye. Normally, the pupil constrict immediately. When remove the pen light, the pupil should dilate immediately. Wait about 20 seconds before testing. Test a consensual light response. Hold both eyelids open, but shine light into one eye only. Watch for constriction in the other pupil, which function of the optic chiasm. Brighten the room and have the conscious patient open their eyes. Observe the eyelids for ptosis or drooping. Check ocular movements. Watch for involuntarily jerking or oculating eye movements. Check eye accommodation. Hold up one finger midline to patient's face and several feet away. Have the patient focus on your finger. Gradually move your finger. This should have eyes coverage of both pupils constrict equally. Test the corneal reflex by touching the whisk of a cotton ball to the cornea. This normally causes an immediate blink effect. Repeat for other eye. Hold the patient eyelids open quickly. Turn patient's head to one side, then the other. If has eye move in the opposite direction from the side to which you turn the head, the reflex is intact. Testing cranial nerves number 1, olfactory nerve. Check first the patency of the nose. Instruct to close the eyes, occlude one nostril at a time, hold familiar substance and ask for identification. Repeat with the other nostrils. Cranial nerve number 2, optic nerve. Check the visual acuity with the use of Snellen's chart. Check for visual field by confrontation test. Check for pupillary reflex, direct and consensual. Cranial nerves 3, 4 and 5, 6, have the patient follow your fingers with their eyes without moving your head. Okay, and then move your fingers side to side, then up and down in an H pattern. Look for a failure movement and mastigus. And then look for failure. Cranial nerve 5 and 7, we have to test for pain, touch, and temperature of the patient with a clean safety pin and hot cold objects. And then to check corneal reflex, gently use a cotton whisk with the patient's cornea. And then test for motor function, have the patient clench their teeth and move their jaw side to side. And then for cranial nerve number 7, sensory portion, prepare a salt, sugar, vinegar, and quantity. Place each substance and anterior 2/3 of the tongue, rinsing the mouth with water. And then for the motor portion, ask the client to make facial expression as forcefully to close the eyelids. And then cranial nerve 8, observe amnestigious and disturbed balance. Test patient's hearing acuity, whisper numbers in each ear while occluding the other. Ask the client to repeat in deafness. If deafness is suspected, perform a Waber and ring turning fork test on the cranial nerve 9 and 10. And then observe the ability to cough, swallow, and talk. Test the motor function by asking the patient to open the mouth and say ah. While you depress the tongue with a tongue blade, observe soft palate uvula. Soft palate and uvula should rise immediately. Cranial nerve 11. To protrude the tongue and note perimetry. And then for assess muscle strength, in patient who obeys commands, assess the patient's ability to move limbs against gravity and resistance in response to a command. Assess and document each limb separately. Observe for differentness from side to side. Arms, assess the straight arm lift, elbow flexion, and extension. And then make sure that the legs are assessed, plantar flexion and dorsiflexion. If the patient does not respond to command, assess document symmetry and strength of each unrestrained limb movement based on assessment of motor function of GCS by observing patient's spontaneous movement or patient's response central pain. Make sure to document the best response of each limb separately on the neurological observation and record. Using the scale of muscle strength, assess for cerebral function, upper extremities. If the patient in bed, hold your finger and have the patient quickly and repeatedly move with his finger back and forth from your finger to his nose. Then have the patient alternately touch their nose with their right and left index fingers. Have the patient repeat this task with their eyes closed. Movement should be precise and smooth. Lower extremities, have patient bend their legs and slide that heel along the opposite shin from knee to the ankle. And then this movement too should be accurate, smooth, and without tremors. If the patient able to stand, you can assess their balance using Ronberg's test. Have the patient stand with their feet together, arms in their sides, and eyes open. He should be able to stand upright with no swaying. If the patient can do that, have them close their eyes and stand until same way. Observe 1 full minute. Because the remainder patient arms are trying to sit whether the patient falls when the eyes are closed, it is advisable to stand ready to catch the falling patient. For large subjects, no, among strong assistant is recommended. Wernberg's test, positive if the patient sway or falls while the patient's eyes are closed. Indicate reproductive or vestibular dysfunction. Evaluate sensation by ask the patient to close their eyes. While testing, evaluate symmetric areas of the body. Begin with the feet and move up the body to the face, comparing one side with other. Assess sensation to touch of light using your fingertips or whisk cotton. Use the test tube with cold and warm water to test temperature sensation. Test superficial pain sensation with clean and a new safety pin. Also test sensation using a dull object. The patient should be able to distinguish sharp and dull. If an object placed on the hands, test preparation position sense by moving patient's toes and fingers up and down. Grasp the digit by sides and have the patient tell you which by way putting. Assess deep tendon reflex biceps. Patient's arm should be flexed slightly with palm and facing up. Hold arm with your thumb and antecubital space over the biceps tendon. Strike your thumb with a hammer. The arm should flex slightly. And for the triceps, patient's arm should be flexed 90 degrees. Now support the arm and strike it just above the elbows between the ependycles. The arm should extend at the elbow. For the bronchioardials, the patient's arm should be flexed slightly and resting on the lap of the palm, facing down. Strike the outer forearm about 2 inches above the wrist, and palm should turn upward as the forearm rotates. Literally. For the patellar with patient's legs dangling if possible, place your hand on the one tight and strike the leg just below and kneecap. The leg should extend at the knee. Achilles tendon with patient's foot in the light dorsiflexion, slightly strike the back of the ankle just above the heel. The foot should plantar flex. Rate according to the following scale. Assess the superficial flex, so plantar reflex only superficial. Assess should be tested in comatose patient with those unexpected lumbar 5 or 5 for sacral 1 and 2 areas of the spinal cord. Stimulate full sole of the foot with a tongue blade or handle of a reflex hammer. Begin at the heel and move up the foot in the continuous motion, the outer aspect of the sole, then across the ball at the base of the big toe. Normal response in the plantar flexion under the toes, circling, extension of the big toe, Babini sign of dermal except in the children younger than 2 years. Assess brainstem reflex by ociocephalic Dahl's eye reflex. Turn patient's head briskly from side to side. The eyes should move to the left while the head is turned from right and vice versa. Is reflex absent, there will be no eye movement. Ocular reflex, eyes caloric and a cold caloric reflex. Physician will instill 2 ml of ice into the patient's ear. With intact of brainstem, ice will move laterally toward affected ear. With a severe brainstem injury, gaze will remain at the midline. Restore, discard all equipment, place patient in comfortable position, then wash your hands. Then for our evaluation with this procedure, we're going to evaluate the client's tolerance of the reaction to the procedure. And then we have to evaluate also the accuracy of the result and compare the findings of those of previous examinations. And then for our documentation, make sure we have to document and record all relevant information and like the date, the time of your assessment, and positive findings, which we first followed by significant negative findings for each of the component. No, that will be all for the neurological assessment. Thank you and God bless.